Hey guys, welcome back to season 2, episode 6 of Baker Health Talks. I'm your co-host Mo. In today's episode, we interviewed Dr. Jeremy Shugar. He's going to be talking about the profound mental health benefits from psychedelics, specifically ketamine. Stay tuned for all your questions.
All right, so welcome everybody. We have a special guest tonight, Dr. Jeremy Shugar, who I've known for quite a while. I've had the privilege of being a part of his teaching and his coming up, and now he will tell us a lot about his history. But it's going to be super interesting about some new treatments that Jeremy does. I'm not going to talk so much because he's got a pretty intricate background. One unique thing is that Dr. Shugar has a background in osteopathic medicine. So for a lot of folks is that there's the MD, which is allopathic world, and then the DO, that's the osteopathic world. And he's certainly by far the most knowledgeable about osteopathic medicine of any doctor I've ever seen. And so I'm happy to have you with us. And go ahead, tell us a little bit about yourself.
And it's like one of the biggest problems we have in our older age community. So excited to see what you have.
Appreciate that, and very kind words. They mean a lot coming from you, Dr. Baker. My background is pretty in terms of kind of getting up to medical school, going to medical school. I had a pretty typical medical education. I went to an osteopathic medical school. Was interested in the osteopathic medicine when I was in medical school. But I also had a lot of traditional interests: infectious disease, primary care, family medicine, like yourself. When I was on my clinical rotations in medical school, I wanted to do an elective in osteopathic medicine. I wanted to kind of see how it can be used a little bit more practically in clinical practice. So dealing with kind of bread and butter stuff, neck pain, back pain. One of the primary reasons people end up in the emergency room, right, or going to their primary care doctor. And when I ended up doing this rotation, I did it in a what you'd call a safety net hospital in the Bronx. And I saw how osteopathic treatment is utilized not only in the outpatient setting, but also in the inpatient setting. And I saw patients getting treated in the intensive care unit, intubated, sedated, multiple lines or drains coming in and out of their abdomen, and seeing how it can kind of really optimize their function in their course in healing. And also saw how it helps people in an ambulatory setting, so in a clinic for chronic musculoskeletal issues, shoulder pain, a rotator cuff injury, back pain, herniated discs, or just bad arthritis in the back. And I really got kind of sucked into that rabbit hole. Really saw how it was able to help people in ways that traditional medicine and traditional modalities don't really tap into. And it's not a criticism of traditional medicine. I think traditional medicine is amazing. What we have today at our resources, someone has an acute infection, we have medications that save lives. We have a major accident or trauma, we have surgeries that save people. But there's, not really, an orphan type of disease or process, but a lot of musculoskeletal issues really they're kind of part of that chronic disease picture. They don't do as well in the Western picture. And I kind of followed my heart. And when I came to the match, I decided to, really go for traditional osteopathic training. And I did that, and I completed a 3-year residency training in a fairly traditional osteopathic medicine that involved both inpatient and outpatient osteopathic care. Subsequent to that, subsequent to my graduation, I held, some faculty positions. I ended up back in the hospital where I did my training as a part-time attending, and then as a full-time attending in a leadership role. Took a hiatus from that, ended up in corporate medicine for a little over a year, really saw how my priorities aligned more with working with people that have more challenging issues. And during that time, I really saw how there's this complicated interplay between both somatic symptoms, chronic pain, musculoskeletal pain, and the behavioral side of things. So one's depression, anxiety, past traumas, PTSD, even things like how obsessive compulsive disorder or anxiety can feed into the nervous system and amplify pain. And you know, in recent years, I kind of tapped into and started reading a little bit about psychedelics, and we're in this kind of psychedelic renaissance now with a rebirthing of different medications that are used for a number of different purposes. There's a lot of research actively going on for things such as MDMA and PTSD, psilocybin, which is active in mushrooms, other medications that are used in other cultures as part of healing and what you would call sacrament use. But within the Western construct, one medicine that kept kind of cropping up in my reading is ketamine. Ketamine is a fairly old medication, been around since the 70s, and really was started for it really started to be used on label, and really the only on label use still is for induction and maintenance of anesthesia in the emergency room, or rather in the operating room. It has a number of off label uses as well. And the primary one off label use is for depression. And when we talk about on label use versus off label use, it's really the difference between what the FDA says is this is a indication for this medicine, and then when practitioners in clinical practice or through anecdote or research start to learn about benefits that lie outside of those FDA approved indications, there's a realm that you could use medications off label, and that happens for a number of different medications. Ketamine started to be used off label for depression because there was this correlation. People started to realize that after surgeries or anesthesias, people's depressive symptoms started to get better, or some of their kind of chronic, more behavioral or mental health challenges were kind of modified somewhat after experiencing ketamine in a traditional clinical setting. And so in, I don't know, past 20 years plus, ketamine's been used and studied extensively and is now very available off-label for the treatment of depression, anxiety, and even chronic pain. And central pain processing disorders like complex regional pain syndrome, fibromyalgia, what used to be called complex regional pain used to be called reflex sympathetic dystrophy, RSD. And the reason for that is its mechanism of action and how it works and how it interferes with a process called central sensitization. So when I say central sensitization, I want to circle back now to the osteopathic work, and that is because some of the work that we do with osteopathy is when we treat the body, and I should maybe cover some of what that means in evaluating the body, is to actually evaluate the nervous system, looking at the vertebral column, looking at how dysfunction and muscle tension and strain can affect normal structure and how that structure can affect function. And there's something to be said for reducing the nociceptive input, the sensory input into the nervous system that can kind of mitigate or reduce how severe someone experiences their chronic pain. So I read a lot about ketamine. I took a training in what's called ketamine-assisted psychotherapy, and have started since integrating ketamine into my osteopathic work for a particular population of patients. And that population of patients tend to really relate to people that have chronic somatic symptoms in the setting of past trauma, depression, anxiety. But I have to use that medicine very carefully, because something we didn't talk about is ketamine and how it works. Ketamine is what's called a dissociative anesthetic, and it has a kind of a dose-dependent effect. For its FDA-indicated purpose, it's to cause anesthesia. That means it puts someone in a state of someone becomes unconscious, and that allows a doctor.
So Jeremy, just to be clear, ketamine is the one that you'd give if somebody, for example, broke their arm and they come to the emergency room and they don't need to go to the operating room, but they need to reduce the arm or put it back. That would be what's given.
That would be what's given as technically actually an off-label use for it. That
Mhm.
would be a procedural sedation
Right.
in an emergency room or a procedural setting.
Right. So in that instance, for those who haven't seen it, it's pretty bizarre how the person looks once they're getting the ketamine, because you can manipulate the joints that you can't do while they're awake, but their eyes are open, they are not with it, and then once everything is complete, exactly what you said, it comes back to um, there's no pain involved. And they're relatively happy afterwards, with not too much pain afterwards. But if you would just go into for a little bit about the mental health part of ketamine for a second, before the pain part of
Absolutely,
it,
yeah, sure.
and in specifically, because the intriguing thing, I think a lot of this and all the research that I've seen, the intriguing thing about ketamine is that it's not indefinite. When somebody's on an antidepressant or a generalized anxiety medication, in the traditional route of medicine, is somebody go ahead and start, whether it's Lexapro or Zoloft or Prozac or whatever SSRI that's indicated for depression or anxiety, and then you're essentially on it indefinitely. A lot of people, most people, for life. Ketamine is different, and they have on the off-label use, but the research. Could you explain a little bit how frequently it's given, the length of time of the infusion, and things that you do when you administer it?
Sure. Yeah. So it's such a good question, and I don't know if we have all. There's a number of different ways to start from answering that question. So from a mental health side of things, and I just want to preface this with I'm not a psychiatrist. I'm not a psychologist. But I am a doctor that works with a lot of people that have a lot of mental health challenges that overlap a lot with the reasons that they come to see us. So that being said, yes, ketamine is not a daily medication. Um, it is used because its mechanism of action is through a different neurotransmitter than the more classical antidepressants or mood stabilizing medications act, and that is primarily through the serotonergic system, also through the dopaminergic system. Ketamine works through the glutamate, the glutamatergic system, which is probably more about half of the neurons in the brain use that neurotransmitter. So the reason it's not a daily medication is ketamine is, so to answer the other question, ketamine is administered in a number of different routes. It could be administered through an intravenous infusion, that is a needle is placed in the vein and an IV bag is hung and someone gets an infusion, usually over the course of about 40 minutes to an hour. And it's during that time that the medication enters into their bloodstream, crosses the blood-brain barrier, and there are the effects of the medication. And there's variability with the effects based on that dosage. And I think we should talk about that dosage in a little bit. The other mechanisms of administration or routes of administration are intramuscular, so it just goes into the muscle. Slightly less what's called bioavailability than through an intravenous, which is basically 99-100%. Through intramuscular is about 93% or so. And then there's also lozenges, where you take a lozenge and it dissolves in the mouth, or through a nasal spray. And those have significantly less bioavailability, from 20-ish% up to about 30%, maybe 40%, depending on individual variability and mucosal status or moisture in the air and so on and so forth. So there's a number of different ways of answering why it is not a daily medication. There's like kind of a reductionist way of looking at it, and that is talking about glutamate, how it has an excitatory effect on the brain as a neurotransmitter, the effects on neuroplasticity and the health of neurons. In depressed people, there's a degree of decreased function in neurons and interneurons and how they function. ketamine actually bolsters neurons and promotes synaptic activity in the brain, and actually exhibits pretty significant and robust antidepressant effects. And those antidepressant effects can be felt quite rapidly. During the infusion, at certain dosages, people may have a sense of euphoria, in addition to a sense of dissociation. The effects of the medication can also be felt hours and days after the medication. And then depending on the frequency that they have the medication administered, depends how what's called durable that effect is. So, and this is highly variable based on each individual. The research shows that, people getting about 6 infusions over the course of a few weeks have the most durable and long-lasting effects. And most infusion centers where you can go to for ketamine actually kind of offer that type of package where they're referencing that research and making that kind of a recommendation for their patients. Some people do.
Is that Jeremy, for the same dosing, like for those who are watching this, somebody who has anxiety, OCD, depression, pain, and the other interesting one is the alcoholism, addiction. Is that the same basic standard package for all of those?
Yeah, so I think there's going to be variability based on the practitioners that you go to and how they run their practices. Different practices are going to, follow different protocols. The recommended protocol for depression, and this is kind of what the research shows, and this kind of comes back to that reductionist way of looking at things, is about 0.5 milligram per kilogram of body weight. So if someone weighs, I don't know, if someone's, what's your weight?
About 190.
So in kilograms, you're about 70,
I-70s, yeah.
let's say 75 kilograms. Then you would get in the vicinity of 38 milligrams of ketamine intravenously. That will produce an effect that is euphoric. You'll have a sense of maybe mildly dissociated from where you are, but there will also be, and now I'm going to kind of talk a little bit about the non-reductionist explanation or reasons why ketamine exhibits or has benefit for mental health. And that is the effects are profound. And this is also, again, dose dependent. So that would be starting you at 38, 40 milligrams would be a safe in terms of, what the evidence shows and what the protocols show. As you start to, play with that dosage, which is a sub-anesthetic dose, right? So we're well below what's being used to induce anesthesia or really dissociate someone for an intense, reduction from a dislocation. The experience is one of euphoria, dissociation, but there's a sense of formlessness or a loss of boundaries. And that's what makes ketamine a kind of a psychedelic medicine. There's this novel sense of self, a novel sense of reality. And that's because ketamine, not all psychedelics, but like most psychedelics, interfere with what's called the default mode network. And the default mode network is exactly that which is the part of the brain or the connections in the brain when we're thinking about ourselves or we're thinking about our challenges or we're thinking about our place in reality. And it's that interruption from the default mode network that, or it's that interruption from our routine sense of self as a result of that interference with our normative way of thinking about things that gives a new perspective. And it's that new perspective that can be very healing and evoke within the individual an innate wisdom or an innate guiding sense of, I don't have to think about myself like this anymore.
And what about head-to-head studies? So if you have somebody who's been on SSRI, the Zolofts of the world, the Lexapros, all the traditional antidepressants, though, because the majority of the people that are doing ketamine are people that have essentially failed or haven't seen the results with the SSRIs. From those people that you've seen and taken care of, what's the success rate that you see with ketamine compared to traditional SSRIs?
Yeah, it's a solid question. So you know, this is going to come more from the literature that I've read and the people that I've worked with and communicated with, and also just anecdotally. Less than half of the population, responds really well to antidepressants, to typical things. Even let's just call it half to just make it easier. For a lot of people that have failed traditional modalities, traditional therapeutic routes, they do really well with ketamine. For whatever reason. Maybe it's because it's working through a different neurotransmitter. Maybe it's because there's a degree of kind of shaking up that normal sense of self. I just kind of want to go back also that it's also the maintenance and the awareness that one has of that novel sense of self, that novel and different perspective of their their preoccupations or fixations or whatever or what have you. Kind of also going back to dosage. When you talk about dosage in the operating room for induction of anesthesia or maintenance, you're talking about much higher doses. 6, 10, 12 milligrams per kilogram. When you're talking about chronic pain, and this is what you see when you read like dosage parameters, even for off-label uses, you're looking at a significant factor well below that, 0.1, 0.2 milligrams per kilogram.
So even not even in the halves.
Not even in the halves.
Significant.
So this is what's so fascinating, and I'm sure that you've heard about the idea of the emergence delirium with ketamine. So as someone is have the anesthetic on board, as they start to metabolize the anesthetic, they're metabolizing through that range that becomes that psychedelic range. So if you administer someone, let's say 10 milligrams per kilogram of ketamine to induce anesthesia, they don't metabolize from 10 to 0. They slowly have a reduction in the serum concentration of circulating ketamine, and they're going to metabolize through this realm that becomes that psychedelic realm or therapeutic realm for therapy purposes or for mental health purposes. And it's that emergence phenomena that they will pre-medicate with other medications so people don't remember it, or it doesn't cause the emergence delirium. And what they're calling delirium is a transient sense of what people would say is the effect of the psychedelic. Some people, psychiatrists, older ways of looking at psychedelics refer them as psychotomimetics or psychomimetics, meaning that it induces a state of psychosis. But it's that state, it's that window, that middle realm between the 0.1, 0.2 that's used for chronic pain versus the 10 for anesthesia. It's that lower middle realm, that sub-anesthetic realm. That's the therapeutic space. That's the therapeutic window. To kind of touch on that therapeutic window, and this gets out of that reductionist way of talking about glutamate. We didn't really talk about the NMDA receptor. We haven't talked about, in the brain, it can be excitatory, in the spinal cord, it could be inhibitory, and, because that's how it affects chronic pain with central sensitization. Stepping outside of that reductionist way of looking at things and looking at it more broadly, looking at it more holistically, looking at it more ceremonially, the experience is arguably really functional in what's therapeutic about the medication for some people. In recreational circles, people that say if they've taken too much ketamine, they call it the K-hole.
When people were taking it recreationally and they get the K-hole, is that when that means the dose is outside of the window, closer to the anesthetic?
You're approaching a dissociative realm, right? It's going to be on a continuum, and it's going to be different for everyone's individual physiology. It's going to be different for everyone's, relationship to the medicine, their own psychedelic experiences, how familiar they are with that. But yeah, as you approach that state that some people argue is actually the state where it can be more therapeutic and transformative because of the insights you capture from being in that space. It is closer to that anesthetic realm. So it's all, it's not like it's not like a stepwise thing. There's going to be gradations from, mild analgesia that you get from a chronic pain dose all the way up to an anesthetic dose. These are very, very broad shades of gray. And everyone can have different experiences, even with the same dose on a different day, can have a different experience based on what stressors are going on, what their intentions are, what their set and setting is. And this kind of comes back a little bit, generally speaking, to, a psychedelic in general, is that, and I don't look at psychedelics at all like a benign thing. They can be very, very powerful medicines when used with intention and in the right set and setting, with the right support and with the right guide. They can be profoundly helpful for some people. But to say that it's just the experience itself without any of the work, I think is equally flawed as to say it's just the mechanism of the action of the medicine. I think it's a really complex interplay.
Jeremy, is there any contraindications like postpartum depression, breastfeeding, pregnancy, age? Like how low can you go in somebody who's really depressed?
Yeah. So quite a shift in questioning yours. There are contraindications, just like with all medications.
I'm gonna keep shifting.
That's fine. Yes. So pregnancy, fairly absolute contraindication. There's
During pregnancy.
during pregnancy.
Okay.
Yeah. Ketamine can interfere with the developing fetus, and so it would be ill-advised, and it would actually be part of your intake questionnaire for someone that might possibly be thinking about having a child. For postpartum depression, however, if a woman is breastfeeding, in my training and from the literature that I've read, you wouldn't want to administer ketamine to a woman that's actively breastfeeding without any guidance. Maybe they would pump and then dispose of the milk maybe for a day, 48 hours after that until it's fully metabolized from the body, and abstain from maybe ketamine proximate to breastfeeding.
And age?
Yeah, so I think that's really variable. I wouldn't, in my practice, I don't work with pediatrics below 18 unless it were in consultation with the pediatrician, maybe to discuss why we're doing this work. Again, I work with people that have chronic, somatic symptoms. That's what I enjoy doing most because of integrating the osteopathic work. And you tend to see kids having less chronic pain than adults. However, I would consider it. I wouldn't go younger than, if I remember correctly, maybe 14. But remember, ketamine is used for procedural sedation in the pediatric emergency room. When I was an intern in the hospital, we gave it to kids for a fingernail in a door, or like you said, a major injury. It's very safe. And maybe before we talk about the contraindications, I'll just touch very briefly on the safety of ketamine. Ketamine is, it might sound scary, psychedelic, dissociative, anesthesia, puts you out, you're not in the room. But it's actually a very safe medication when used responsibly and in the right setting and in the right indication. Unlike other medications like opiates, it doesn't suppress the respiratory drive. It maintains primitive reflexes, airway protection. So within those dosages, and that you use clinically for these in the mental health realm, and what I'm using in the somatic / mental health realm. When you watch someone, it's a very safe medication. It does cause a transient increase in blood pressure. So for people that have uncontrolled hypertension, that would be a contraindication or a relative contraindication. You'd want to make sure that they get their blood pressure under control. People that have thyroid issues, it can kick someone into a hyperthyroid state. So for people that have hyperthyroidism, You'd want their thyroid disease to be under control in concert maybe with the endocrinologist, or just making sure that they're on their medications. An interesting concern with ketamine, and this is really more for people within the recreational circles, is this phenomena of ketamine-induced cystitis. And the metabolite of ketamine, norketamine, actually can be irritating and inflammatory to the bladder wall. And for people that use large dosages of it and experience symptoms and continue to use it, it can actually cause permanent damage to the bladder wall. So monitoring patients for bladder irritation, sense of urgency, suprapubic discomfort or pain after having a ketamine would be a reason to stop, reevaluate, reassess, and take a look. So people with a history of bladder disease or I'd say genital urinary tract, issues would be a reason to, give pause. Other safety factors, and I'll touch on age in a minute, would relate to people with maybe borderline personality disorder. Remember, we talked about before psychedelics in general having psychotomimetic effects. So it can induce states of delirium or psychosis in someone that might be more vulnerable to it. So it is relatively contraindicated for people that have a history of borderline personality disorder or other psychotic disorders or psychotic features. In terms of age, I think that as people get older, cardiovascular stability, maintaining adequate kind of, what's the word I'm looking for? Cardiovascular stability and I think just like normal mentation as people get older. You don't want someone to get disoriented, confused on any type of medication. I think that's a relative concern. So this is where evaluating people responsibly in the best interest of the patient and making sure that you're covering all bases. But the big ones, the big things you think about are uncontrolled hypertension, thyroid disease, bladder disease, some mental health challenges or psychiatric illnesses, and then people that have a history of arrhythmias or cardiac disease is another one, because one of the effects with ketamine is that there is a transient kind of effect on norepinephrine. And so someone really needs to be kind of exercise tolerant. If someone can run a mile without restrictions, it's probably okay. But part of evaluating everybody is taking a proper and thorough history, getting a blood pressure, checking their pulse ox, doing a physical exam, listening to heart and lungs, doing a neurologic exam. I'm pretty thorough, and that's just because I'm a little bit more risk averse. I'm not saying other people aren't thorough, but
and do you see in when it comes to what seems your specialty when it comes to the pain aspect of it and incorporating the osteopathic part? So a lot of the people that you take care of, they are on OxyContin, right? Percocet, whatever, any controlled pain substance. Once you start to do the ketamine for the pain, how quickly do you see them start to get off of the prior addictive medication?
Yeah, so before I go there, you bring up one other thing to think about, and that is other medications that people might be on in terms of safety. So some of those medications absolutely relate to narcotics. Someone that's on any long-standing narcotic, when combined with another medication, can cause oversedation. So weaning someone or, working in concert with maybe their prescribing doctor, can we maybe lower the dose, start with a lower dose of ketamine, and then play with it and go from there. Opiates are absolutely one. Benzodiazepines are another, and certain anti-seizure medications benzodiazepines and anti-seizure medications can actually interfere with some of the effects of the ketamine. So they're actually ill-advised to combine them because it might be subtherapeutic. I think
so somebody is coming in with an addiction to benzodiazepines, so the Xanaxes of the world, things like that. That is not indication to start ketamine?
It can be. I mean, this is where I would probably communicate with their pain management doctor or their psychiatrist that's prescribing these these other medications, because I wouldn't want someone to come in on their normal dose of benzodiazepines and then become over sedated. While ketamine itself doesn't suppress the respiratory drive, the concept of synergy and the concept of multi polypharmacy can result in some kind of idiosyncratic or whatever type of effects. And so I would be very cautious with that. Addiction is absolutely an indication for a trial of ketamine, because it is part of that. Why is the individual addicted to the medication? What is it that they're seeking from that? What is their relationship to the addiction and the process of addiction? But I would still be cautious about maintaining them on their routine dose before initiating a trial of ketamine to see how they respond to the ketamine. And that's why I would do it in concert with this goes to a general concept in medicine, and that is, we know what we know when we become doctors, right? And we're afraid to say, I don't know. And we're afraid to call for help sometimes. I'm not saying this is everybody, but the idea of the interdisciplinary care framework is like super important to me. And I really emphasize that in my clinical work with people. I have no qualms about saying, I don't know, let me do a little research, let me get back to you, and let me talk to your doctor and the other person, and maybe a friend of mine that knows a little bit about this. So back to your question, how quickly do you start to see an improvement? I think that's going to be variable based on the person. How bad is their pain? What is the etiology of their chronic pain? Do they have a spinal cord injury, or do they have is their chronic pain a result of chronic back pain, and they're on a lower dose opiate that they're taking, and they kind of want to get off of it because they realize it's not really addressing the underlying problem. Like a lot of things in medicine, and this is, again, it's not a criticism, but there's a lot of Band-Aids in modern Western medicine. Antihypertensives don't treat the underlying cause of hypertension. In the same way, chronic opiate use does not treat the underlying cause of the chronic pain. It is a mask for a dysregulated and pathological process that is much deeper than an opiate is going to fix.
And can you just now explain a little operationally for this? So, like, if somebody's coming to your or a doctor's location to go do the ketamine, and they're taking it, and it's going to be an hour, is it like just an infusion room? Do they need somebody to bring them, to drive them and drive them back? And is the same thing in regards for the injection, the intramuscular injection?
So I'll answer what I understand to be the case in other practices. I don't do that. I run a house call service. So I believe that, and this is just how I work and how I operate. I believe that people are most receptive to healing and confronting their challenges, and really connecting and being most comfortable in their own private space. So I run a house call service, and I bring everything to the patient's home. So within a clinical practice, a traditional private practice, yes, people go to an office. It's generally recommended someone drive them there, or they have a friend with them. They are there for the duration of the experience or the infusion. They should be monitored for about 1 hour once the medication has worn off or the patient's landed, and then evaluated for safety for discharge. I personally recommend that people do not drive for the remainder of the day, because while, again, ketamine is fast on and fast off, and people tend to come back to baseline after about an hour or so, you're still a little groggy, you're still a little, maybe a little spacey, you're not 100% baseline. If something were to happen to the person, my number one concern is always patient safety. And so within that, yes, they should have a chaperone, someone to drive them, someone to take them to or from if they're using public transportation. You don't want someone to trip on a sidewalk or get disoriented and walk into traffic. These are real world considerations.
And the majority, from your experience that you're doing, are they usually infusion form, or are they intramuscular?
That I work with?
Yes.
I work with ketamine in an intramuscular form, because when I'm doing the osteopathic work, I want to be able to transition between the journey experience to the osteopathic work pretty seamlessly.
So you're doing the osteopathic work while
Yeah.
after the injection.
Such a good question. No, I don't. And I'll explain why in a second. I don't use IV. It's more moving parts. It's more invasive. You're carrying bags of fluid with you, lines. There's just more that can go wrong. I don't put my hands on someone other than being your supportive guide, which would be a hand to hold or a hand on the shoulder for comfort when someone is in that space. I don't do anything more than that when someone is having the medication experience. Part of my evaluation, my physical exam and determination for eligibility of this work, that includes a traditional physical exam, heart, lungs, blood pressure, pulse ox, so on and so forth, is an osteopathic structural examination. During that structural examination, I identify areas of what's called somatic dysfunction, which has diagnosable features, has characteristic features that you look for on exam. And during that examination, I bring awareness to the patient that these are areas that I recognize as being integral or functional in some of their symptoms. And I point it out to them. And then I will treat some of those areas osteopathically beforehand with very gentle modalities, gentle techniques. After I've done the work, I will transition to where they will then receive the medication. And then it gets to be what looks a little bit more ceremonial or ritualistic. A period, play some music, maybe burn some sage, have them center, and administer the medication. And they will lay in a peaceful and quiet place, blindfolds on, non-lyrical music is played, and they have the psychedelic experience. During that time, I don't do any osteopathic treatment. And I don't for a number of reasons that are both optical and practical. You don't want someone to think anything untoward is happening. This is a very powerful medication and someone's in a very vulnerable space. And I work with people that have a lot of trauma where they've been taken advantage of. And so part of the dialogue and part of the getting to know the patient is making it very clear that none of that happens during the journey experience. Once they've landed and the medication has worn off, then I will do some more osteopathic reevaluation and work and have them explore some of those areas as well. I bring awareness to the areas of somatic dysfunction beforehand, because there's something to be said that while they're internally focused and they're having the experience, there's a degree of capability or capacity for that kind of self-somatic work and self-breath work and exploration that people can go through. Where are they feeling their pain? Moving around that space in their body. We all stretch, we all do yoga, we all do breath work. Not we all, but many people do these types of things. And with the adjunct of the medication, it can help people explore those areas from a place of non-bias, without fear of judgment. And they're able to engage that area a little bit easier, and make that part of their healing. So it's that synergy of the antidepressant effect of the medication, the anxiolytic effect of the medication, their ability to look at themselves from a different perspective, combined with the somatic input or the reduction in somatic input that my practice really focuses on in synergistically alleviating some of those chronic issues. Because it's not like we have a mind and a body and that they're these separate things. When people are more depressed or they're more anxious or they're reliving some of their trauma, they also don't feel as well physically. Their somatic symptoms are worse.
That's great. That's great. From those who I've seen that do use the psychedelics, ketamine, etc., for depression and anxiety and addiction, I don't know of anybody that goes to the house. And the rationale that you use for why doing the home visit on this person that needs it, it's exactly right. It's exactly similar to when people do a sleep study outside of their home. It's very rare for that sleep study to come back normal.
Mm-hmm.
because you're already outside of the comfort zone, but then the partner that's sleeping in bed with the person who has those symptoms says, I don't know what to tell you. They're snoring, they're moving, they're all that. So by leaving somebody in their comfort zone, do you find that gives them the biggest chance of success?
This is probably a pretty good sized gorilla to talk about in Western medicine. We've depersonalized and taken circumstance out of so much. A sleep study being done. Why, yes, I think that the idea of someone being in their native place where they feel most comfortable is going to drive and potentiate the efficacy and the response to treatment. The idea of going somewhere else to do something takes someone out of where they normally are.
By the way, is there family members there when they're getting this done?
If they choose to have family members there, yes.
Because that whole experience that you described, that like ritualistic thing, you kind of see why people back in the 70s and 80s would do this recreationally. It seems very, very, dare I say, fun.
Dare you say?
Fun.
Fun.
For them. That's why people were using it in such a recreational thing. And but back to this place. So your whole experience when you go to the person's home, so you perform osteopathic manipulations to sort of bring to light what the issue is, whether it's back pain, neck pain, shoulder pain, whatever it is, and then you administer. Let's say in this particular instance, it's an intramuscular injection. So you give the intramuscular injection, and then so if it's not the infusion is about 60 minutes.
Yeah, 40 minutes. Yeah,
40 minutes. So is the effect after you do the injection? Is that about the same time frame?
The duration's similar.
Similar?
The duration's similar.
So your whole time there is about an hour, 2 hours or so?
I spend far more than 2 hours in the person's home. Because I'll explain why.
Please.
So, a medical evaluation, it's not just about, again, it's not just the physicality. It's also, who is this person that's now in front of me? Maybe I've spoken to them on the phone. Maybe I will go there and just do the physical exam and the osteopathic exam and a little osteopathic work first. And then I will come back to do a little bit more osteopathic work and then the ketamine experience on another visit, because I want them to feel comfortable with me. I want to optimize and really promote the most robust experience. If I go to someone's house for the first time and now there's a stranger in their home, and at first they're like, oh, I'm fine with this person. They're a doctor. I trust them. And then they're in an altered space and they don't really trust me. I'm not looking to rush anything.
Sure.
I'm going to charge the person the same amount of money. I'm not looking to spread things out to get more out of the dynamic. The most important thing to me is to see how we can transcend modern options and really create the most therapeutic landscape for healing. And that's going to happen on their terms and their time. It's not going to happen on my time. And that's another layer to a lot of, our medicalization, is that it's happening on I don't want to sound cynical, but it's happening on the terms of the medical industrial complex. Patients have to go here. They have to do this. They have to get this study.
Sure.
They're at the behest of the recommendation. And that's the standard of care. And we operate.
Speaking of the medical industrial complex, this treatment, is it covered by insurance?
Good question. So, ketamine, this is a nuanced answer. Ketamine, when we use the word ketamine, is not covered by insurance. And that's because ketamine is an off-label medication. And to my understanding, off-label medications are not covered by insurance. I don't know, if you wrote someone for gabapentin for anxiety, would that be covered by insurance? They maybe be given gabapentin for neuropathic pain on paper, but then it would be covered by insurance because that's what it's used for, is neuropathic pain. But there's an off-label use for gabapentin. So ketamine, as we say the word ketamine, it is not covered by insurance. What is covered by insurance is maybe the psychotherapy that may accompany the ketamine experience. But I just want to kind of highlight one thing. ketamine, when we say ketamine, that is the injectable form of ketamine is what's called a racemic mixture of ketamine. And a racemic mixture is in what's called an R and an S form of the molecule. They're mirror images of the same thing. So this is my right hand and this is my left hand. So this is the R form of my hand and this is the S form of my hand. So it's those it's a 50-50 mixture of the ketamine molecule. Spravato is a nasal spray form of ketamine that is S-ketamine. That is the S enantiomer of ketamine, the S-type ketamine only that's been isolated from the racemic mixture. And that is FDA approved for treatment-resistant depression with an antidepressant. It's very expensive and needs to be after someone's failed other two other medications. That is covered by insurance, and it only exists in the form of a nasal spray. There's different things about S-ketamine versus R-ketamine, S-ketamine being more potent or more psychedelic or whatever. The research shows that the racemic mixture of the injectable form of ketamine is most efficacious. I don't want to get into that nuance. It's outside the scope of this.
And how much is it when it's not covered by the ketamine?
It depends where you go. Different infusion centers charge different amounts for an infusion.
Yeah.
If you go to, I don't want to mention any particular names, but I've seen anywhere from about $650 or $550 per infusion, all the way up to $800. But they usually offer like package deals in order to kind of maximize and follow that 6 treatment protocol. There are lozenge form of ketamine that's available via a telehealth visit with a doctor. There are different companies that mail the lozenge to the home, and patients can take the ketamine lozenge in the home and follow the kind of protocol that way. I have certain opinions about that, but again, that's outside the scope of this talk. To my understanding, that also is not covered by insurance, but the telehealth visit may be as it relates to mental health, the psychotherapy, and the kind of the supportive framework that's part of that. One thing I want to emphasize with ketamine work in general, and all psychedelic work is just like a blanket thing, is just like other tools out there, it's not about the medication. It's a tool. Meditation, yoga, breath work, exercise, these are tools. And it's that interdisciplinary care. The evidence shows that ketamine, when used as part of in a psychotherapeutic and supportive structured framework, is the most efficacious. So when we say ketamine-assisted psychotherapy, it literally means ketamine-assisted psychotherapy. You have this thing to help someone on their journey to tackle their challenges that they've been facing and that haven't been responding to other modalities. In the same way, antidepressants with psychotherapy is going to be more beneficial to someone. There's synergy with talk therapy and a medication in the same way. So I think that's just really important to emphasize. Again, I'm CAP trained, ketamine assisted psychotherapy trained, but I'm not a psychologist. I'm not a psychotherapist. I learned to, and I've adapted my own supportive framework to help guide someone through the experience, to confront their challenges, to engage their challenges, and to really be willing to have a experience that deviates from everything that we've been taught or conditioned to believe as what is routine is the way it should be. It deviates from, it seemingly deviates from the norm, but it's actually become very common that that's the case. The other layer to what needs to be emphasized is, when someone does a lower dose of a psychedelic and they're still present in the room, you'd say it's like a psycholytic. It helps kind of break the ice a little bit. It makes it a little bit easier to engage things that someone would otherwise be reluctant to engage or talk about, like a past trauma, like their challenges, like their anxieties or their depression, or what triggered it in the first place. And so that's also instrumental in the efficacy of the therapy that comes from being in that place and in that state. The prototype or the example of that is with MDMA-assisted psychotherapy for veterans, and that's a really big and hot topic now. And for the listeners that are paying attention to the landscape, the FDA is supposed to be evaluating MDMA as a legitimate form or adjunct for MDMA-assisted psychotherapy. And that stems a lot from research that came working with veterans and trauma and PTSD.
And do you do that as well?
MDMA is a Schedule 1 controlled substance. It is only available in research settings right now. I don't work with that professionally. It's outside of my wheelhouse. People that work with it should be trained to work with it. It is also a very powerful medication. It is also considered to be a psychedelic because it interferes with how one would normally look at themselves and their trauma and their relationship with their trauma. There are practitioners that work with MDMA, what we would say is below ground, because people don't have any other options. But there's a lot of research, in and around even New York, Mount Sinai and NYU. They have, centers for psychedelic studies that are looking at these different medicines and using them within the context to assist with psychotherapy. And then the other layer, just going back to ketamine, is that also just having that supportive person. There's this concept of integration that we haven't talked about. Integration is the idea of, you have this journey experience where you are taken out of your normal sense of self, your normal sense of reality, your routine fixations or what you're preoccupied with, and you capture something from that experience. You're kind of given ingredients to work with. What do you do with that after the experience? You don't want to just be then, catapulted back into your everyday life with this baggage that you don't know what to handle, what to do with it. So this concept of integration is actually probably just as important as the experience itself. And that is, what is it showing you? What is it teaching you? What inner wisdom are you evoking through the experience that you're telling yourself that these are the real bits and pieces that you need to work with? What is the trauma that you are unpacking through what is the experience? How is the experience unpacking your trauma that you will then work with and talk through in subsequent psychotherapy visits when you don't have the medicine on board? So, and I just want to emphasize how important that is within the dialogue, because it's not about the ketamine. It's about what comes from within, that the ketamine simply helps you get there. In the same way, what comes from deep meditation that allows someone to tap into something inside of them that is integral in their function and functional in their healing and in their growth.
No, it makes sense. It makes a lot of sense.
I had a lot of questions that you asked and he answered. First, I want to get your thoughts on the Knicks off-season moves.
I think they were strong.
You think Bridges puts them over the hump?
No.
Conference finals?
I put it at injury-free. Injury-free, yes. With the moves that happened in Philly, I think that Philly is a lock. So it's probably going to still be Philly and Boston.
I mean, that's if Philly stays healthy.
Yeah.
I mean, all those guys, they're like... I saw a tweet today. It was like a picture of Maxey, Harden, and... Maxey, Embiid, and Paul George, and it was like out, probable, questionable.
Right. Yeah, but that's still statistically going to be the Eastern Conference.
And then one more question. Oh, your thoughts on all the soccer going on?
Argentina wins the Copa America and Spain, Europe.
And then the UFC this past weekend. Alex Pereira is a beast.
I think he's one of the top dogs in the UFC.
The guy who saved the card, Danny Ige,
pretty wild.
Wild. Did you see his walkout song?
I did.
DMX.
Not. That's a great pick.
Great pick, and he had to do it in less than 3 hours.
That's a great pick.
Yeah, but that's all I got for tonight.
Good. Well, thank you for coming. That was awesome. We got to have you back. We got to have you back for more discussion about the psychedelics in the behavioral health space and addiction space. Each one of them can go on for hours.
It's a bit of a rabbit hole. There's a lot to talk about that extends well just beyond the depression or the anxiety or these kind of prototypical things. I mean, there's a lot to be said just in terms of just the challenges associated with navigating day-to-day life.
That's awesome.
There's absolutely there's more to be said, more to talk about.
That was awesome. Thanks for coming, brother.
Pleasure.